Good day, everyone. I'm Ann Bailey, and I will be the facilitator for today's webinar. I'd like to welcome you all to the Vizient, formerly known as the VHA-UHC, Hospital Engagement Network Knowledge Network Series. We are very proud to provide you with an array of accredited educational webinars featuring national subject matter experts and leading practice hospitals in all of the focus areas for the Partnership for Patients. One of those focus areas is adverse drug events. We have 3 web programs within this focus area. Anticoagulation, which we had with Dr. David Rosenberg from North Shore on January 27th, and one on insulin that is planned for March 16th with Paul Zamita from the Brigham and Women's. Today's webinar will feature the 3rd topic, adverse drug events related to opiates. Before I introduce our speakers, I have a couple of housekeeping details to cover. Firstly, all attendees are on a listen-only mode. The program is being recorded. The program recording link will be sent to everyone registered or attending this webinar. Please feel free to forward the recording to any of your colleagues who might benefit from the content of today's program. After the program, those of you that have logged into today's webinar will receive a program evaluation via email. Once you complete the program evaluation, you will be immediately directed to your continuing education certificate. Please note that this will be a personalized email and should not be forwarded to anyone. If there are other people in the room with you today who have not logged into the program, please be sure to send their names and email addresses to Roxanne Maddox, and her email is roxy, R-O-X-Y, .maddox, M-A-D-D-E-X, at Vizient Inc., that's VIZIENTINC.com. Once we receive their names, we will send them their personalized email with a link to their program evaluation and continuing education certificate. If you missed that email, Stephanie is going to put it in the chat box. Again, if you're logged in for this meeting, you do not need to send us your information. You will automatically receive the email with a program evaluation. If you take a look at slide 2, I'd like to report that none of the Planning Committee members nor faculty have anything to disclose. I'd also like to mention that it is important to recognize that the value in these web programs comes from the speakers' presentations as well as audience participation and interaction. Please ask questions and share your own experiences and challenges. Use the chat function for questions or comments at any time. We'll review the questions after the formal presentation, and if you're on a phone line only, you can press *1 to ask a question. So let's get started. Our speakers today are Dr. Go and Ann Jankowitz. We're delighted to have them to join us today and share their work in strategies to decrease harm from opiates. They're from Rush University Medical Center, where Dr. Go is a hospitalist and Ann Jankowitz is a medication safety officer. So at this time, I'm going to turn the call over to Ann Jankowitz.
Good morning. A little background to set the stage for our presentation. Opioids are used widely in the inpatient setting for management of acute and chronic pain. Unfortunately, adverse events related to opioid administrations can result in oversedation and respiratory depression. At Rush University Medical Center, we have implemented a variety of interventions that aim to decrease the incidence of these events. All of our naloxone administrations for the last 2 years were reviewed in detail. It is unclear at this time if this is our best measure of our efforts, but we have not identified a good alternative at this time. Our approach has been to target critical areas in the ordering, administering, and monitoring of opioids. This slide shows the number of naloxone cases that we have in fiscal year 15. Our denominator is the unique patients who received opioids while admitted. Patients receiving naloxone in the ED for opioids taken prior to admission are excluded from this measure. Our average for fiscal year 15 were about 11 naloxone cases per month. Our average would need to drop to about 8 cases per month to reach our goal of 0.41%. This goal was set as 25% decrease from our previous fiscal year average. This control chart shows that our naloxone use has been pretty steady over the past few years. Our numbers are relatively low. We will always have cases where naloxone is used almost as a rule-out, and this has led us to look for other measures. We do not want to discourage naloxone use if it's needed. In October and November of 2015, we saw that there were few more cases than usual of naloxone use, and again looked at the cases in detail to find trends or areas to concentrate our work. We found 5 drivers that were identified, and these are to improve post-procedural management of pain meds, to recognize clinical decline, ensure ordering practices reflect patient need and clearly defined administration goals, to reduce the inappropriate use of naloxone, and to ensure proper screening of patients pre-op or upon admission. In regards to reducing the inappropriate use of naloxone, I just want to let you know that these cases are counted in our metric. We were trying to use a metric that we would not have to do a manual case review with each naloxone case, but we have found that this might not be possible in order to get the true opioid oversedation cases if we continue to use naloxone as a measure. More details on our key drivers for oversedation include an unrealistic expectation of patients regarding pain control, inappropriately high opioid doses being ordered, for example, morphine 2 milligrams every 8 minutes for PCAs in opioid-naive patients, the lack of awareness regarding comorbidities that place patients at higher risk for oversedation, such as sleep apnea, concomitant benzodiazepines, sedatives, antiemetics, and muscle relaxant administration. And this is becoming more evident with the use of more multimodal order panels in the postoperative setting, and the lack of adequate monitoring of patients receiving opioids. We have seen some problems with pain scores. In 2000, the Joint Commission had mandated that pain be considered the 5th vital sign. This has led to escalating doses of pain meds being used to decrease patients' pain, and this is often tied to pain score ranges, where nurses at times give pain meds too close together due to multiple orders for the same medication based on pain score. And patients often default to saying they have 10 out of 10 pain because they don't understand the pain scale. So then we looked at changing how we measure pain. The Defense and Veterans Pain Rating Scale is a functional pain scale. It links functional capability to a numeric score, and it's intended to have more accurate pain rating. We instituted the DVPRS as our pain scale in January of 2015. We placed a laminated version of this diagram in all the patients' rooms, and we asked RNs to ask scripted questions to help the patient determine a more accurate pain scale. Some of the benefits that we've seen to the DVPRS pain scale include a common language to communicate pain among providers. It helps patients communicate how pain affects their life. It creates a pain dialogue between the clinician and patient. It helps structure a clinician-patient discussion on pain, and it aids in setting interdisciplinary pain goals with the patient.
So this is Ann Go now, and I'm going to talk a little bit about how we have tried to improve our ordering practices. So just a little bit of background, we usually have about somewhere between 100 and 120 internal medicine patients admitted to internal medicine. And almost all of these patients are actually covered by internal medicine residents. So the result of that is that most of the, actually almost 100% of these orders on these patients are put in by internal medicine residents. So we thought we had better address the fact that they need to know how to order opioids safely and correctly. So in July of last year, we did a safety course for the new medicine interns, and one of the lectures they got was on medication safety, which included opioid safety. And we actually polled them at the time that they got this lecture and asked them how many of them had received any training, formal training on how to prescribe opioids, and only 19% of them had any sort of training. So as a result, we managed to actually change the curriculum of their year at that time, and they all the medicine interns now do not do 1 week of outpatient gynae, and instead they now have to spend 1 week on the inpatient palliative care service so that they can receive a little bit of formal education on this topic. And then in order to have something for them to have as they went about their daily duties, we created a pain pocket card with opioid conversions that we tried to distribute to all the medicine residents. So I'm going to let you see what this looks like. So this is the front of the card, and the front mostly focuses on how to convert between IV and oral, and then between the narcotics that we use the most, which are morphine, hydromorphone, dilaudid, and then oxycodone. So the top does the main conversions for these, and then the bottom gives you all the permutations of converting between IV and PO, dilaudid, and morphine, and what the appropriate multipliers are. Then on the back of the card, we put down adjunct information that we thought would be helpful around the prescribing of opioids. So at the top here on the left, we have the website for the Illinois Prescription Monitoring Program. And here in Illinois, we are able to look up all the narcotic prescriptions. I think it goes back for several years that a patient has filled, and it'll tell you who the prescriber was and which hospital or clinic it was associated with. So this is useful to find out what the patient's outpatient narcotic usage actually is. And then in the second half of this middle part of the left column, we thought it was important to do a little bit of education around naloxone because as Ann Jankowicz explained, naloxone is the measure that we are using in terms of how well we're doing with opioid oversedation. And as she mentioned before, we do see sort of over and over again that there are cases of naloxone administration when there is not really respiratory depression or hypoxia or cyanosis, which are the real indications for giving naloxone. We seem to see like every couple of months cases where a patient is confused, but their respiratory rate appears to be 20, and then they get naloxone for confusion, which is not really an indication. So we thought it was important to do a little education around that. And then on the right side of this card, it's just some hints about side effects from opioids and how to manage them. So it talks about doing a scheduled bowel regimen, and then how to deal with nausea, vomiting, and pruritus if those issues should come up. So this card, as I said, was distributed to all the medicine residents, and as far as I can tell in my time on the medicine floors, a good number of them do have them in their pockets and hopefully are using them. So obviously that only deals with internal medicine residents, and this issue of opioid sedation is significant enough such that our hospital administration felt that the education needed to extend to the rest of the hospital. So a multidisciplinary team of nurses, physicians, pharmacists, and respiratory therapists was created and came up with an interprofessional educational module. And the module had 3 parts. The first part was assigned to everybody in the whole hospital, and talked about reducing opioid-induced respiratory depression. There was a second part that was for RNs and respiratory therapists and talked about assessment considerations. And then the third part was opioid prescribing tips. So the opioid prescribing part was assigned to all physicians in the hospital, which included residents, attendings, and advanced practice providers. So this was everybody. So, it ranged from everybody in internal medicine to all the subspecialists to neurosurgery, orthopedics, general surgery. And the module focused on opioid equivalencies, conservative starting doses, and identifying patients at risk for oversedation. So it was assigned to everybody, and all the department chairs were supposed to try to force everybody to do the module. At the end, it appeared to have been completed by 72% of all the medical staff, which is obviously not 100%, and I can just hope that it raised some awareness for this problem to some proportion of the staff. So another thing that we've done to try to improve our ordering practices is to try to use our electronic medical record, which here what we have is Epic. So we've recently created an internal medicine pain module, which is an order set that just went live last month. So we don't have that much information yet about this in terms of its usage. So this pain module stratifies patients into high risk versus average risk for oversedation. And so a patient would be considered high risk if they have 2 or more of the following. So if their age is greater than 70, their BMI is greater than 35, they have sleep apnea, pulmonary insufficiency, meaning COPD, concurrent CNS depressants, and smoking. So Epic is able to extract some of this information and help provide information about age and BMI. Some of the other risk factors are a little harder to extract if they're not populated into the problem list. And then as we mentioned briefly, sometimes OSA is not necessarily something that people are even diagnosed with, and they could just be a suspected OSA patient, so that's a little harder to sometimes pinpoint. So the order set tries to steer ordering for high-risk patients to lower doses and longer administration intervals. First of all, what's recommended, though, is to try to see whether non-opioid pain medications can be ordered, and it actually suggests to try to schedule round-the-clock Tylenol or ibuprofen or Ultram to start with that first. Obviously, we do have a lot of patients with chronic kidney disease on our medicine floors, so sometimes it's not really an option to do scheduled NSAIDs. But I think the problem is that lots of times people don't really even try Tylenol as a solution for pain, so it tries to put this to the forefront. And then unless the patient is strict NPO, oxycodone IR 5 milligrams is suggested as a starting dose. So if you're a high-risk patient, then you would be dosed every 6 hours PRN, and then an average risk patient is dosed every 4 hours PRN. So one cultural thing that we're going to have to try to change is that our default oral narcotic has been Norco, the hydrocodone Tylenol combination. And I think we used a lot of that in the past because you didn't really have to provide your DEA, and now that's changed. So we thought that it would be good to maybe switch over to oxycodone IR because there's no confounding the Tylenol issue, where we definitely have patients that take Norco and then on top of that are taking extra Tylenol, and then the Tylenol dose starts to get close to that 3,000 milligram threshold that we don't want to exceed. And then going back to the order set, the starting dose of IV morphine, if you really are NPO, is 1 milligram every 6 hours for a high-risk patient. For an average risk patient, the suggested starting is 2 milligrams and at a Q4-hour interval. So this pain module also includes nursing orders for increased monitoring and vital signs every 4 hours, whereas on an internal medicine floor, the default vital sign frequency is Q shift or every 8 hours. And it also includes the POS, which is the Passero Opioid Sedation Scale, which Ann Jankowicz is going to talk a little bit more about later, and what the required respiratory assessment is. And then it also includes suggestions for a standing bowel regimen. So the order set tries to group not only the ordering but the assessment and adjunctive orders that should be thought about when ordering opioids altogether. So we're hoping that we can get the internal medicine residents to start using this order set for just so that they do a better assessment of a patient's risk of oversedation. So obviously this order set doesn't cover everybody on a medicine floor. So other populations that we have tried to think about, if a patient has a creatinine clearance less than 30 or end-stage renal disease, the prescriber is directed to a separate order set that we have for opioids in renal failure. And the intent here is to not use morphine in renal failure because morphine has too many active metabolites that are not dialyzable. So the choices in the order set for opioids in renal failure are oxycodone, 5 milligrams, or oral dilaudid, and the suggested interval for those is like 2 6-hour PRN dosing. And then for the IV dilaudid, the suggested starting dose is to start with 0.3 milligrams every 4 hours PRN. So that's for our renal failure population. And then another population that isn't covered very well by the order set would be the chronic pain patients. And the problem with the chronic pain patients is that they're on widely varying pain regimens. So it's hard to just squeeze them all into one order set, because we have some patients that are on 30 milligrams TID of MS content, and then we definitely have some patients here at Rush that are on 600 milligrams TID, 900 milligrams TID of MS content, and that is what they have been on for years. So the pain order set suggests that for a chronic pain patient, that you restart their home medicines and then obtain a palliative care consult. So our palliative care team has constructed guidelines for us for managing patients with chronic non-malignant pain. So examples of this would be people with chronic back pain, functional abdominal pain, fibromyalgia. So we don't want to lump cancer patients in this category, and we decided also that sickle cell is probably not good to lump into this group of patients. So our approach for managing chronic non-malignant pain, number one is to check the Illinois Prescription Monitoring Program, which I talked about a little before. And the key thing here is to make sure you actually know what patients are taking as an outpatient, because we have run into problems with patients stating that they take this X high amount of narcotic as an outpatient, and then the overnight team will order them that medication, and then in the morning they are over-sedated and barely responsive, and then when the Illinois Prescription Monitoring Program is checked, it's discovered that this is the dose that they maybe filled a year ago and they haven't filled anything else, and they asked for a dose that was just inappropriate for them at this point in time. Second, urine toxicology screen should be done on admission to figure out whether you're dealing with any illicit substances that might be confounding the picture. Once again, we want to use the functional pain scale and also set functional goals every day, which can be as simple as saying that your goal is to get out of bed and walk around the unit 3 times each day, and tries to bring the focus away from saying I have 10 out of 10 pain and I need to lie in bed every day. And then the key, I think, thing is at the bottom, which is to do team rounding every morning, which includes the general medicine attending, the palliative care attending, the internal medicine residents, and the nurse for the day. And so this whole team goes to see the patient in the morning, discusses the plan for the day, which would include the functional goals and what the pain medications are going to be. So then this plan is delivered with everyone present. And also another key thing is that the pain medication doses are only changed once a day, and that is laid out in front of everybody. And this avoids the issue of some patients trying to split the team by saying this person said I could have this, and then assorted members of the team are going in and out of the patient room at different times and being played off against each other.
Okay, one of our drivers is the lack of adequate monitoring. So we looked at improving monitoring of patients on opioids. Nursing is on the front line when it comes to monitoring patients on opioids. And previously we used the RASS, which is the Richmond Agitation Sedation Scale, to determine patients' level of sedation in all patients. We put together the IPE, or the Interprofessional Educational Module, to introduce POS, which is the Passero Opioid Sedation Scale. And our intention was there to use the POS for unintentional sedation and to continue the RASS scale to be used for intentional sedation, and that is what is present in some of our infusions that are used to intentionally sedate patients. The POS has 5 levels of sedation. Each level has a recommendation for appropriate action. Here you can see the Passero opioid-induced sedation scale, or POS, where S is equal to sleep, and then you see 1 to 4 with increasing sedation levels. A patient receiving a score of 3 is the target for intervention, and some of the suggested interventions is to decrease the interval and or dose of the opioid, consider switching to a non-opioid pain medication, taking away the PCA button or epidural PCEA button if those were prescribed. And it also requires the nurse to do an assessment of the patient, looking at the pain report, doing a full respiratory assessment, and also to monitor respiratory status and sedation until the pain score is less than 3. What we want to do is to catch patients at a POS of 3 and take action before they reach a POS of 4 and then require naloxone or BiPAP or intubation. The IPE module was done by our staff in June of 2015, and one of the goals of the education was that greater than 90% of the nurses at our UMC would demonstrate accurate and consistent use of the interventions within 3 months of implementation of the training module. And this included the use of the appropriate sedation scale and reassessment of pain and sedation at the time necessary. We know in the medication safety arena that education is not the most successful way to change behavior or prevent errors, and we found this to be true in our audits. In July, only 15% of cases had appropriate assessments of pain and sedation. We developed an FAQ document and put this out in late July, and we saw that our numbers rose to about 20 to 25%, but these were still not great. Some of the reasons for the inappropriate documentation included nurses documenting both the POS and the ROS sedation scales, no sedation scale at the time of administration or the wrong sedation scale, or no reassessment within 120 minutes of pain medication administration. I have been meeting since that time with nursing groups to identify some of our barriers to assessment and documentation, and we identified some confusion with our electronic medical record, and we are working to simplify flow sheets where the nurses document pain and sedation. We are also looking at doing education using case reviews with smaller groups to assure understanding of the concepts. This is a picture or a screenshot of our pain report. We worked on optimizing how clinicians can see all the necessary information that they might need when making decisions on ordering or administering pain meds. So this is a pain report that is available in our electronic medical record, and over the years we've added more information that we thought was useful. Now you can see the creatinine clearance in the patient header, the patient's BMI, if they have a history of sleep apnea. We see all the pain scores and sedation scales, all the pain medications that they are receiving, including PCAs and epidurals or infusions, their vital signs, the respiratory rate, rhythm, and quality, which is part of the updated respiratory assessment. And we can also see at the bottom the CNS depressants and CNS infusions that a patient might be on that contributes to sedation.
So in conclusion, this is Dr. Go again. As you can see, the issue of oversedation from opioids is really multifactorial and multidisciplinary, and we are still struggling with a way to find like a good metric to measure the effects of our interventions. We have our naloxone metric, which you saw the data for previously. But we know that there are cases that don't get naloxone and go straight to intubation, which will not be counted in this metric. And we know that there are patients that get oversedated, and they are watched, and they eventually get up, and those people aren't counted in our metrics either. So overall, however, we do feel strongly that our interventions are contributing to improving patient safety, even though we may not have the most robust measures to actually show that this is true. And then I just wanted to end with some of the future projects that we are working on currently, but these are in the works. So as Ann Jankowicz mentioned, we're looking to constraining doses on our PCAs in terms of the intervals and starting doses. And as she mentioned before, it is possible in our hospital to start on a morphine PCA at a 2 milligram dose with 8-minute lockout. So we have seen several cases where opioid naive 70-year-olds have managed to get 30 milligrams of IV morphine within 2 hours or so, and not surprisingly, they are oversedated and they get naloxone. So we're hoping to maybe at least cut down the dose to maybe 1 milligram and maybe increase the interval to 10 milligram, or I'm sorry, the interval to 10 minutes or 12 minutes. And then we are hoping to re-examine the multimodal post-op order sets, as Ann Jankowicz also spoke about a little bit before. And obviously this is a big thing in the surgical world. And I think the goal of these multimodal approaches was to try to decrease opioid use. However, the problem is that some of these other medicines are very sedating. So what we see is that people are getting good doses of Neurontin and Flexeril, and then they get a narcotic on top of it. And not surprisingly, we see oversedation. So we're hoping that maybe we could at least look at these order sets and maybe dial back the dose of the narcotics administered a little bit. Our barrier here is that we have so many post-op order sets in our institution. The neurosurgery people have them, and they're different order sets depending on the surgery you have. The same thing for orthopedics and then for general surgery. So it requires a lot of going through all these very separate order sets and getting the people to own these order sets, who own these order sets, to agree to changes. And a lot of these order sets have different owners. Thirdly, we're hoping to somehow or other come up with better screening for OSA patients, because as you know, many people with OSA are not diagnosed. The problem here is that a lot of times, especially for surgery, patients from surgery are funneled into the system from outside primary care doctors here. Sometimes they only see anesthesia beforehand. So the problem is that it may be noted in their pre-op note that they are OSA or at risk for OSA. That information just does not get translated or transmitted to the person that is ordering the post-op pain medicines. Because the person that orders the post-op pain medicines is most of the time a resident, and it is really never the person that does the pre-op. So there's no way to transmit that information to the person that orders. Fourthly, we're trying to figure out whether we can only allow one medication to be administered for any pain score between 4 and 10. As Ann Jankowicz talked about earlier, we have the 1 to 3, 4 to 6, 7 to 10 pain score, and for a lot of patients, each of these scores is tied to an escalating dose of narcotics. And what happens is that patients end up getting stacking doses of increasingly higher doses of medicines because there's 3 different medicines ordered, and they can sometimes end up getting things at Q1 to 2 hour intervals, which is not the intent of how the medicines were really written. We are also hoping to eliminate administration of additional IV and oral opiates if a patient is already on a PCA. And then lastly, we're thinking about switching to fentanyl PCAs for all our renal failure patients. This has been tried in our renal transplant population already with very good results. They didn't have any adverse events. And fentanyl probably is the best drug to use for renal failure patients. So that's something that we are considering as a possibility for renal failure patients who need PCAs. So that concludes our presentation, and hopefully this was helpful to some of you out there. And I think we'd also like to hear about other interventions, maybe people, and we can do this in the question and answer period, that other people have attempted, or any other comments or questions.
Well, thank you very much, Dr. Go and Ann, for sharing your very comprehensive approach to decreasing harm from opiates. I think this showcases that this is really a process of learning, that there's no magic bullet, but I appreciate you telling us what you're up to and what's working and what you're focused on. So now for the audience, it's time for your questions. And as a reminder, you can type your questions or comments, any thoughts that you have, anything you'd like the speakers to respond to, by using the chat feature. If you're on the phone line, please just dial *1 and you'll be able to ask a question that way. So I do have a question from Marilyn. Have you found that pain scores are lower using the new pain scale?
Hi, this is Ann Jankowitz. No, we have not found that the pain scores are lower. We have found that the DVPRS is not consistently being used, and that is part of the second wave of education or case reviews that we'll be using with nurses. For a while, there were two places to document pain in our flow sheets for nurses, and we found the DVPRS score was lower, but that the patient's reported score was higher. So the nurses felt by looking at their functional capabilities that they might have been at a lower score, but we are looking to have the patient's reported pain scale as the only pain score, and more work to be done with DVPRS.
Okay, great. Thank you, Ann, and thanks for that question, Marilyn. I got another question here from Carol. Do you do any screening prior to starting therapy for opioid naive versus tolerant?
So this is Ann Go. So I'm not. I'm assuming that screening means checking to see what they actually. But maybe I'm not answering the question. So it's not really clear to me whether screening means verifying that they don't take any narcotics at home or whether they do. In terms of other screening, I mean, we have the Illinois prescription monitoring database that you can check. And then otherwise, in terms of knowing whether somebody is opioid naive, it really sort of depends on somebody actually doing good medicine reconciliation at the point of admission to find out what somebody has actually been taking at home. So we don't have a formal process for opioids specifically, but we have sort of done a lot of education in general with our residents on the importance of doing good medicine reconciliation at the point of admission to make sure that everything downstream runs a little bit more smoothly.
Can you say a little bit more about that, what you do with the residents?
Well, I think we try to reiterate to them that if you do not do the medicine reconciliation at the beginning, you're not going to know what they were taking at home, which affects multiple areas of care. So we try to get people to say what they've actually been taking at home in terms of their narcotics. Mm-hmm. And then if there's any question, you can try to check up on the Illinois prescription monitoring program. But that's about, I think that's about the limit of what we can do in order to try to determine if somebody is opioid naive or opioid tolerant. And on our order set, it defines our internal medicine order set. It defines sort of very clearly for the user what opioid tolerant actually is. So it gives how much oral morphine, fentanyl, oxy, IR, Dilaudid you should be taking a day, and that it should be more than 7 days that you've been taking this amount that makes you opioid tolerant. So we have the definition up there for them
right
of
there.
What naive versus tolerant actually is.
Okay, excellent. And Carol commented again that I think she was talking about documenting assessment of what was or was not taken prior to admission.
Yes, but that goes back to the whole medicine reconciliation issue, which is another whole terrible bugbear for us that extends beyond narcotics.
Right. Do you find sometimes that the patient isn't? How does the patient fit into all that?
Well, sometimes people are vague.
Yes.
So it's hard to tell. Sometimes people overstate what they're taking, or like I mentioned earlier, sometimes people will say, "Oh yes, I take 8 milligrams of Dilaudid every 4 hours," and you look on their prescription monitoring printout, and they haven't had a prescription filled at all, in 3 months. In which case, then that's probably not a good point to start them on. So, I mean, it does require some cross-checking, especially if you
Right.
feel like you're being maybe tricked a little bit.
Yes, excellent point. Thank you, Carol, for that question. I've got another question here from Adam. How have pharmacists verifying orders contributed to efforts towards safer and more appropriate prescribing?
I would love to say that it has really helped, but I do think that because of the complicated order sets and the number of opioid and CNS depressants that are ordered at the same time, that I don't think that the pharmacists, if they're just verifying orders, they're not at the patient's bedside or not during rounds, they feel empowered to make many changes. And we also do not have a clear picture of what is really going on with the patient. If we, at the time of verification, if there's a pharmacist covering multiple patients, would not always have the time to look at the Illinois Prescription Monitoring Program and to get that information. So we do look at the home med list and other meds they're on. We have the pain report, but it's sad to say that I don't think the pain report is used as many times as we think they should be using it. And we've even had some duplicate therapy safety events with pharmacists not catching duplicate therapy. So again, the education is ongoing to try to put as many tools in our electronic medical records to make this easier process for them.
That's great. Thanks. Thanks, Adam, for that question. A question from Thomas. How do you address relative cross-tolerance when converting doses using the equivalent dose cards?
So the dose cards just list the regular or like the standard converting doses that you'll find in the literature and in some of the dose or opioid calculator conversions. And we do have one of those, the global RPH we use as a link in our electronic medical record. But it really is up to the clinician to look at cross-tolerance and to put a value in. I know often we teach, at least with the pharmacist, to just do the conversion and then to drop it by a percent, a 10-20% drop in the converted dose to allow for cross-tolerance. But it's not an exact science, I don't believe.
Okay, great. Thank you. Thanks, Thomas, for the question. A question here from Sarah. Do you use PRN non-opioid options? And if so, how do you order these in addition to opioids?
So the PRN non-opioid options are often used for the pain score of 1 to 3 in our order set. So we may see, Tylenol used at that time or ibuprofen. And it's in addition to the opioids because, again, we're right now we've built most of our order sets with a drug for the 1 to 3, 4 to 6, and 7 to 10. So you may see 3 different medications being ordered. We have also tried to put ketorolac, either PRN and scheduled in some of our surgery or post-op order sets, again for lower pain scores, and then the higher pain scores having an opioid.
Okay, great. Thank you, Sarah, for that question. Another question from Adam. What specific restrictions do you have on IV opioid use, and how are these restrictions enforced?
So right now the only thing that I'm thinking of as far as IV opioids is that IV fentanyl, IV push, is restricted to the ICU areas. If it's used outside the ICU, it is the MD is to be present while the dose is being administered. The information is on the in the MAR, so the nurses will know if it's something that's restricted, and also the pharmacist sees these same restrictions when they're verifying orders. So it would be on the nurse, and the physician sees it, I guess, at the time of ordering. They see the restrictions. The pharmacist would intervene if the order was there for verification. Oftentimes the nurses see the order and already call about that. As far as PCAs, we do have some restrictions in ordering of hydromorphone and fentanyl at this time, but again, we are looking at taking off some of the restrictions because at the time we put them, maybe the dosing of hydromorphone and fentanyl may have not been as widely known or used, but we feel that maybe some of these restrictions is preventing us from using hydromorphone and fentanyl in the renal failure or renal dysfunction patients that we could be using them and maybe avoiding some of the oversedation we're seeing with morphine.
But we don't really have any restrictions on using just straight IV morphine or IV dilaudid as IV pushes.
Okay, thank you. Thanks, Adam, for that question. I'm going to pause here and ask Marche if there are any questions on the phone line.
And there are no audio questions at this time.
Okay, thank you. So once again, I'd encourage folks to either dial *1 to ask a question or to go ahead and type your question into chat. Or if you have an intervention that is working well at your organization, please share that as well. I've got a question here from Marilyn. Do you have a pain team in addition to the palliative care team?
Our pain, in terms of like having specific teams, we only have two teams, and that's anesthesia pain, and they actually focus a little bit more on doing, blocks and procedures. And they do have their own chronic pain patients that they'll come see from their clinics when they'll come see them when they are admitted. And then we have palliative care, which are internal medicine, usually internal medicine / geriatrics doctors that we can also consult for pain management. And at least on internal medicine, we tend to do more of the palliative care versus the anesthesia, and tend to just do anesthesia when we want procedures done for pain, and do palliative care when it's just pain medicine management.
Okay, great. Thank you. Thanks, Marilyn, for that question. I have a question here from Sarah. If patients do not use 0 to 10 pain scale, that is, they're assessed using behavioral scales, how do you order opioids because the 4 to 10 scale will not apply?
I think even with our behavioral pain scales and even with the DVPRS, we ask questions to get to assess their function or their what they can do. Can they talk on the phone? Can they walk the halls? But those do get assessed using once you've determined where they are, it does equal a number. So there's always a number put into the pain assessment row of the flow sheet, and then you can use the pain medication that goes with that number.
Okay, great. Thank you, Sarah, for that question. Again, any questions you have, feel free to type those into chat, or if you have anything that you want to share with the group about what you're doing, that would be great to hear too. I have a question about the whole issue of education. You've talked a lot about different things that you're doing to educate the staff and clinicians and so forth, but that sometimes that's not the most effective way. What do you think is the best thing to supplement the education with, or how do you think the delivery of the education should be so it's the most ideal way to do it?
So I was working on the project that worked with the interprofessional education. I mean, if you look at the medication safety literature, most of the ways to prevent medication errors is to put some hard wiring into either your electronic medical record or into your policies or your procedures so that you would prevent someone from ordering too much morphine or at too small of a frequency. Oftentimes there's limitations with electronic medical records. Everyone wants to put an alert to stop physicians or others from ordering the wrong amounts, but then you have alert fatigue, so it's kind of a balancing act. Education is needed, and what we really wanted to do first with our educational program was to do more of a case-based learning, small groups, but we found with trying to educate, over 1,000 staff members, if you looked at all the disciplines, that seemed to be cumbersome. And what we used was what we call LEAP modules, and these are almost like a webinar that the staff member will go and look at slides, listen to the audio. There were some cases built into the module, but we have found that sometimes staff click through the different slides or don't really learn very well from those modules. So we really feel that we need to go back and with the smaller discipline areas, as internal medicine has done, as Dr. Go said, coming to safety conferences, to noon conferences, and to doing some question and answers and repeated messaging about the safe use of opioids and appropriate use of naloxone. And then now with the nurses, again, going from unit to unit with the unit manager or maybe with the pharmacist and doing case presentations so that it's more one-on-one teaching, because we found that the overall interprofessional education, even though it was viewed by 70 to 80% of the staff, didn't have the impact that we were looking for with our the use of the sedation scales, respiratory assessments, and even the PAS scores. So we've seen PAS scores of 3 where opioids continue at the same dose. So there's definitely, even though there's information, if they click into the box on our electronic medical record, they will see, to take action, it's not being done.
Mm-hmm. And Dr. Go, do you have anything to add to that?
Well, I think from the point of view of medicine, it is really sort of incumbent, I think, on our medicine attendings to model the behavior that we want our residents to learn. So it all, it comes from the top down, because the residents really sort of, are guided by what we tell them to do. Mm-hmm. So when I am on the floors, I really try to, reiterate, if this person is on narco and you're going to switch to morphine, do you know, how much you are giving? And does that seem like a sane or insane dose that you're ordering? And so I think we just have to sort of chip away at it one resident at a time and try to sort of teach them, and, and they in turn actually teach their interns. And it has to sort of come, I think, top down.
Yeah, I think that's really important information. It's not just a one-time thing. It's as you say, chipping away. Or it's a process of kind of
changing practices,
coming back, and right. So you're then monitoring it, because the other issue that we're all struggle with is once you found something that's working, how do you sustain that? And I know a lot of this stuff is newer, but do you have any comments, either of you, on the whole idea of sustaining the best practice?
I think it's having overarching principles. I know we had that years ago when we were first developing our order sets, and I think we will have to continue to do that. And some of the principles that we talked about during our presentation on lowering doses of morphine PCA, building that right into the order sets and maybe hardwiring some of these, taking away certain dose buttons or frequencies, that is going to be the way to sustain it. And then also, if we have an annual review of order sets, to have a champion that speaks at each of these order set meetings to talk about these guiding principles of the use of lower doses, of screening a patient for being naive or tolerant to begin with, OSA screening. I mean, really just to try to build it as much as possible into the electronic medical record and just into our standard of practice.
Excellent. Thank you. I'll ask Marcia, are there any calls on the phone line?
And there are no audio questions at this time.
Thank you very much. I've got another question here about patient and family engagement. That's something that all organizations that are in the hospital engagement network are looking at across all the clinical areas. Could you both comment on how patients and families either are engaged or can be engaged? Your thoughts on that?
Well, I would say that our experience so far tends towards families being a little too engaged in sometimes managing their family members' pain medicines. And sometimes that's kind of the problem, because I feel like sometimes, we get family members pressing people's PCAs for them, and there's just sometimes a little too much of what family members think is helpful but doesn't end up being helpful. But I think this also just goes back probably to education again, and
Right.
I think we really have to sort of try to get people to understand that we are not trying to withhold things from you. We're just trying to sort of do things in the safest possible way, where we treat you, but we don't put you at risk to be oversedated and have a little trip to the ICU that that was not a planned part of your admission.
Right.
So. And this, as we talked about, this education piece of it is just very difficult to affect when sometimes people have very fixed ideas in their mind of what their care should be like.
Mm-hmm.
And I think it goes back to some of the things that we talked about in establishing goals for the patient. So if the family members were present when we talked about rounding and establishing a pain goal. So if a patient's pain is at 7 or 8, a realistic goal may to bring them to 5 or 6. It may not bring them to 0. And establishing these goals and having that conversation with both the patient and the family. Or what would be realistic in post-op day 1 versus post-op day 3. So I do think it's engaging them at the time that some of these goals are being addressed.
Yeah, that's really important. We're getting close to the end, but I'd like to ask each of you if you have any parting thoughts or recommendations where organizations that are on the line can take your key takeaway, or keeping in mind that the organizations on listening to this program are sort of from all over the place, different sized organizations, different shaped organizations. Where would you say is it your recommendation as to where to start going on this, where to focus?
Because we were not able to find one driver that I think would solve the case of opioid oversedation, I think it's just to keep an open mind as to the multidisciplinary and I don't want to use the word multimodal, but the multimodal way of dealing with it. I think we will need to look at our electronic medical record, the use of order sets, just some guiding principles. What does the hospital itself want to have as the best, like maybe they just pick one opioid to concentrate on. I mean, I think now we're going to look, like we mentioned, at PCAs. And then education, I think it needs to be repetitive, and I do think it needs to be more case-based and more of a small group or one-on-one sessions in order to make a difference.
Great. Thank you. Dr. Go?
I mean, I think overall, probably like this whole country just needs to use less opioids in general. Because I think, prescription opioid use and the number has just like skyrocketed in the last, I guess, like 15 years. And I think the pendulum has kind of swung one way where like I think opioids were the answer for everything, and I think it's kind of swinging back a little bit. And I think we just need to be more judicious about our use of opioids, which I think then would help like this issue of people getting oversedated.
Yeah, thank you. I think there's certainly more attention being placed on that. Let's watch and see what happens. Okay, well, we've come to the program end. I'd like to thank both speakers, Ann Go, MD, and Ann Jankowicz, PharmD, and all of the attendees for participating today. If you have any remaining questions, you can type them into chat, and we'll make sure that you get an answer. I'd also like to direct your attention to the last slide, which lists the upcoming events for the HEN Knowledge Network series. So you can take a look at those, pass that information on to others in your organization that might be interested in a particular topic. And if you have any questions or you want to register, you'll see the email address at the bottom, hen@vizientinc.com. So thanks again to our speakers from Rush University Medical Center and to all of you for participating on today's program. Have a great day.
Ladies and gentlemen, that does conclude the webinar call for today. We thank you for your participation and ask that you please disconnect your line.